Hi, Bill Richards here again. As president, it gives me great pleasure to introduce our next lecture, the Henry Laws II lecture, to be given by Dr. Barry Inabnet. Innovation and technology, essential elements to nurture leadership and drive strategic change. This lecture is named after Henry Laws, to honor his contributions to the Congress and the field of surgery. Dr. Laws joined the Congress in 1967 and served as president in 1997 to 1998. He received the Distinguished Service Award in 2012. During his surgical career, Dr. Laws was in private practice, served on the faculty of the University of Alabama, Birmingham, was a director of the surgical residency at Caraway Methodist Medical Center, and was a surgeon at the Norwood Clinic. Dr. Laws had a passion not only for clinical care, but also for medical education. Dr. Laws passed away on February 25th, 2014, at the age of 81. Dr. Laws was a frequent visitor here at the Southeastern Surgical Congress. He was a great, great surgeon. Enthusiastic and everything else. Let me tell you a little bit about our speaker. Dr. Barry Inabnet is the Johnson Wright Endowed Professor and Chair of Surgery at the University of Kentucky. In 2019, he joined the college from the Mount Sinai Health System, where he was the Eugene W. Friedman, MD, Professor of Surgery, System Chief of Endocrine Surgery for the 8-hospital Mount Sinai Health System, and co-director of the Mount Sinai Adrenal Center. From 2014 to 2018, Dr. Inabnet served as chair of surgery at Mount Sinai Beth Israel and oversaw the integration of that facility into the Mount Sinai Health System. Dr. Inabnet attended the University of North Carolina at Chapel Hill, where he received his undergraduate and medical school education. He completed his residency in general surgery at Rush Medical College and Rush Presbyterian St. Luke's Medical Center in Chicago, Illinois. Dr. Inabnet then completed a fellowship in endocrine surgery at Cochin Hospital in Paris, France, where he received specialty training in endocrine surgery and minimally invasive techniques. Dr. Inabnet has pioneered new techniques in minimal access endocrine neck surgery, as well as adrenal and pancreatic surgery. Dr. Inabnet was among the first surgeons in the United States to introduce and adopt remote access thyroid surgery. He is also a leader in the field of metabolic surgery with an interest in disorders of the endocrine surgery and endocrine system in obese patients, especially type 2 diabetes and malignancy. He's held numerous leadership positions in AAES, ASMBS, American College of Surgeons, and ATA. Dr. Inabnet has authored more than 200 peer-reviewed articles. He's in book chapters and 6 textbooks. He lectures throughout the world and was inducted into the Southern Surgical Association, the American Surgical Association, the French National Academy of Surgery, and the French Academy of Medicine, becoming only the 4th U.S. surgeon to achieve this honor. I would say I've known Barry for many years. He's really a Renaissance leader, surgeon, great friend, and it's been such a pleasure to serve with him on so many different committees at SAGES and at the American College of Surgeons of video-based education. He's a fantastic, like I said, Renaissance leader, and I'll have him come up and deliver his lecture.
Thank you so much for that incredible introduction. Goodness gracious. It is such an honor to be here today. And in fact, I think some of us were talking, the last meeting that I attended, and many of us, was the Southern Surgical Association a year and a half ago. So it's great to have these in-person interactions and to learn and share knowledge and develop new friendships. Also, I have a confession. This is my first Southeastern Surgical Congress that I've attended. I was scheduled to be in New Orleans, but I had a sudden change of plans due to some events in Lexington. But I noticed on the emblem, New York, the cutoff was New Jersey, Delaware, and Pennsylvania. So New York didn't make the cut. So now that I'm back in the South, it's great to be here today. I have no disclosures other than there's not going to be a lot of data in this presentation. This is going to be a lot of stories that I tell through personal experience, observations, and from stories of the folks that I worked with over the years. First, a few words about Dr. Laws. I think Dr. Richards provided some great background, and I certainly think the title of my presentation is very appropriate because Dr. Laws was in fact an innovator. Little did I know until I was researching his career that from 1989 to 1992, he oversaw a laparoscopic practicum course at the Auburn Veterinary School, and per his obituary, over 600 surgeons from 7 countries attended that course. So he really made a major impact in the early days of laparoscopic surgery. And in fact, I'm going to talk a little bit about that. And in his retirement, I noted that he enjoyed growing oak trees, quail hunting, and fly fishing. And those are 3 of my passions. So I'm really humbled and honored to be giving this esteemed lecture today. So here are my observations about technology, innovation, and leadership. First of all, innovators are often isolated and singled out, and in fact, even ostracized in many cases. Innovation is a team sport, but often in a team sport, you need a leader. And I think I'll demonstrate that through one of my stories here. Leadership and innovation are essential in resource-strained environments. And I think that certainly is something that is very true. And finally, crisis provides an opportunity to leverage technology and innovation and an opportunity for leadership. So first, I'd just like to give a plug for the University of Kentucky. I've been there 2 years now. I started in August of 2019. So this is my 2-year anniversary. And these are the 7 pillars that guide our department. And you'll see many of these themes intertwined in my presentation today, whether it's DEI. We actually have an outreach to high school in Lexington, leadership, education, innovation, global surgery. These are all very important aspects of the culture, the growing culture of our Department of Surgery. So first, innovators and their ideas are often isolated, ostracized, and then ultimately accepted. And I think Dr. Sharma's great presentation with a slide about the early adopters and that bell-shaped curve was really interesting to me. This requires dynamic and resilient leadership. So here's a picture about a year ago of Oak Island, North Carolina, where our family has had a beach house for over 60 years. And Hurricane Isaiah came in. It was only a Category 1, but the storm hit at high tide, full moon, and the water surge was devastating. And having had experienced many hurricanes over the course of my life there, this is by far the worst damage that the island has sustained since Hurricane Hazel in the 1950s. We arrived, and my nephew and myself, the island was under quarantine. You had to be a homeowner to get on the island, and we didn't know where to begin. We just rolled up our sleeves and we started to plow through what needed to be done. And on the way off the island, I came across this sign on the bridge, and I was like, wow, look at that. Where are we going? So in fact, this is very appropriate for innovation. Sometimes when you start with an idea, you don't know where it's going to go, but often it ends up in a place where you had no idea the idea was going to go to. And I think that certainly is relevant to my talk today. Many of you may know the story, some of you may not, but the story of Eric Mew certainly is really interesting. He's a German surgeon, or was a German surgeon, and on September 12th, 1985, he performed the first laparoscopic cholecystectomy. He was stimulated by the laparoscopic appendectomy that was performed by his German colleague, Dr. Sim, in 1980. He developed a working instrument that allowed to remove the gallbladder, distend gallbladder through a single port. And he presented his work in 1986 at the German Surgical Society, but the old surgical establishment, really butchered him, ostracized him, and he was viewed as a renegade, an outcast. And he also had trouble speaking in English, and this contributed to sort of the overall dynamic of the situation. Things got worse in 1987 when he operated on a patient, and the patient died post-operatively, and the death was mistakenly attributed to the technique, but in fact, there was other cause for the death. He actually was charged with manslaughter and imprisoned. Just a terrible story. But after further investigation and early adoption of laparoscopic cholecystectomy technique, he was vindicated and ultimately exonerated of this egregious crime that he supposedly committed. So a really valuable story where an innovator really required resilience to persevere. Now, here's the story of transoral endoscopic thyroidectomy. I attended the World Congress of Surgery in 2015 in Bangkok, and my good friend and surgeon colleague Ankun Anawan presented his first 60 cases of transoral endoscopic thyroidectomy with no complications. No one could believe that this was even possible or true. Needless to say, in the United States, we were already performing transaxillary, the BABA approach from the chest. We were already doing some pretty novel techniques, but no one could really believe that this was even possible. So in August, about a year later, exactly a year later, in 2016, a team of us went to Bangkok to observe Ankun and work. So you can see Ankun with the arrow. Here's Quan Du from UCSF and his partner Insu Sa, Robin Cisco from Stanford, Tony Bernardo from Cornell, myself and my partner Gustavo, many other surgeons. We spent a week there, and it was the most amazing academic trip I think I've ever taken. We would go to the operating room, watch 2 cases, go out to lunch, come back, watch another case, go back to the hotel, take a nap or work out, and then go out to dinner. We did that for 7 days. It was awesome. Food is really good at Bangkok, by the way. But there were some interesting things. What we realized is that the technique really is reproducible. And after the first case, we immediately realized this is really an invaluable technique that will be here to stay. We have to worry about the mental nerve, something that you don't really worry about in traditional thyroid surgery. And actually, Ankun was not the innovator. He was an early adopter, and then he made some early innovations in the technique. So Dr. Wang in China actually developed the technique after the Germans had tried to go in under the tongue, which really did not work. Dr. Wang moved the incisions to the oral vestibule, but he made these lateral incisions really close to the mental foramen. So there was almost 100% mental nerve injury rate in an early experience. Well, Ankun went and spent 6 months with Professor Wang, and then basically moved these lateral incisions up more anterior in a lateral direction. And that simple maneuver changed the technique and made it much more safe to perform. So here we are watching him operate. Here's Quan Du and us gathered around Ankun, who's very much our junior, but very advanced in his knowledge base and just a masterful technical surgeon. So here is a short video, and these are my colleagues at Mount Sinai that I worked with for many, many years and who are still very, very close with. So we started out doing BABA, and with BABA, you make the incisions. We use a robot. You make the periolar incisions, axillary incisions, and you get a sort of a traditional anterior view of the thyroid gland. So here are the strap muscles, and then you basically do the operation beginning from the bottom up to the top. So you're approaching from the south, but it certainly makes intuitive sense. What if you were to approach the gland from the north as opposed to from the south and start at the superior pole vessels and then end up with the inferior portion of the dissection? So here we make the incisions in the oral vestibule, and I'm going to spare you the video in its entirety, but I'll just show a few bits and pieces. Here we're doing hydrodissection with a Varus needle. And it's important that we use a bariatric length Varus needle because the shorter 12-millimeter Varus doesn't reach. We do blunt dissection with a vein tunneler and then basically insert the trocars. And then much like you would with the early hernia operations, we create the working space under direct vision. And this is sort of the initial view. This is what it looks like. You basically get your instruments in and you create these tunnels or connect the dots between these tunnels that we created with the blunt dissection. And a lot of the time is spent developing the working space, but you can see it's under direct vision. You work our way down to the sternal notch. And here you do the operation. There's the thyroid gland. The isthmus has been divided. Working on the superior pole vessels. And there's the carotid artery. I think you can appreciate the wonderful visualization. And then the gland is retracted in a medial direction. And here you can see the insertion site of the recurrent laryngeal nerve, and you can see the superior parathyroid gland. And basically you create this tunnel and then the operation is done. And then the specimen is extracted through by placing it in a sac and then extracted through the oral vestibule. So we were not the first group to perform this technique in the United States. We were the second group, but we were the first to publish. And it was a video accepted to surgical endoscopy, a video abstract. And of course, the press went wild with this. This was picked up by Medscape. You can see this is December of 2016. And I just want you to see some of the comments. I don't really use social media that much. I try not to, but I was kind of intrigued by these comments. Why? Don't understand the purpose of this other than to make a simple procedure complicated and impressive. This is retarded. I'm stunned an IRB would approve this. Most amazing, innovation beyond imagination. Is this dumber than the robotic approach? Re-report, you decide. I do not understand the necessity of this procedure. Really, what on the earth is the purpose of this? I'd like to know the incidence of recurrent nerve injuries. Oh, for crying out loud. Congrats. This is a very interesting approach. I mean, you have to have thick skin if you're going to be an innovator and not take this personally. But clearly, just like the excellent trauma rotation presentation we heard earlier, you have to plow forward, have thick skin, and stick to your principles. What these folks don't know is what the patients experience. This is a patient that I operated on in New York, and you can see this is 1 week post-operatively. There's no evidence that she's even had an operation. It's not for everyone. It's not something that is going to take over thyroid surgery, but it definitely has a role. And here's about a year ago, this is my first case in Lexington of a patient who has a history of keloid formation, a very appropriate indication, and a very happy patient with an excellent result. Again, I'm not going to present data. There's a lot of studies showing the safety of this technique, but I'm just presenting the concept of innovation and leadership. And I love Edward Deming, quality crosses borders without visas, and there's no substitute for knowledge. So next, innovation is a team sport that is enhanced by a defined leader. So I had the great privilege of working with an amazing team from 1998 to 2003 at Mount Sinai, New York. So our fearless leader was Michel Gagne. He's had, I don't know how many firsts in the world of techniques he's developed, including the first endoscopic thyroidectomy. And there's Alphonse Pomp. He always was taking the fellows out for sushi on rollerblades. There's Dan Heron. He was our innovator, the gadget guy. I was a runner. So here's my head and neck surgery book. And then here's Terry Quinn, who was one of our fellows we hired for faculty. She stayed with us for a couple of years before moving on. And just a great, great team. One day, Michelle said, hey, would you like to perform a gastric bypass? I think you'd be good at it. And I was like, okay. That's how I became a metabolic surgeon. Now, think about that. Things really have changed with the way we train our fellows, but we really developed, we were I think, the first laparoscopic bariatric program in the country. And I don't want to make that bold statement, but I think that is true. A lot of innovation happening. And if you look at this time of year, I can remember telling patients, you have a 1% chance of dying from your operation. I cannot imagine telling that to a patient in modern times. This is 20 plus years ago. But a dramatic uptick, and it was sort of the wild, wild west. The transition from open to laparoscopic surgery, developing new techniques, and the outcomes were not so good. These are some of our programs' unfortunate outcomes: internal hernias, dead bowel, fistulas, diversion. This is a take back from another surgeon in the community who did a very, very large gastric pouch that led to some problems that needed to be revised. And the press was going wild with this. They were not so enamored by the early days of laparoscopic bariatric surgery. Dr. Richards can attest to this. And it wasn't until really we began to take matters into our own hands and to collect data and to understand the data that we began to improve performance. You can see sleeve gastrectomy got a CPT code in 2008, and that's when basically it replaced banding and is now the most common procedure. But from this point on, when we developed the sleeve, it really was an unlisted gastric code, and so the penetration was not so high. Now, the college has had a long tradition of promoting quality from its inception all the way up to the publication of the Red Book in 2018. And Dr. Hoyt, of course, his legacy will be his implementation of the quality verification programs that Dr. Sharma mentioned in his presentation earlier today. I was very involved with the early days of the Bariatric Surgery Center Network, which was the precursor of the MBSA QIP program, and very much participated in the writing of the standards. And it's somewhat ironic that I started just as, hey, once you do a gastric bypass, I think you'll be good at it. And then I was very involved with actually creating standards for other surgeons through training pathway. You can see, though, after the collection of data in a short period of time, we were able to demonstrate a marked improvement in morbidity and mortality in the two most commonly performed operations. So going back to 99, no one had really, except for Alan Whitgrove, was really performing gastric bypass. So we had to kind of create an operation. In fact, our first 500 patients, we did the wrong configuration of the Rulin. We had it twisted the wrong way, and we had a lot of internal hernias. So we began to close Peterson space. We realigned our the proper orientation, and we began to train surgeons in how to do this technique. Now, Michelle went on to develop the laparoscopic duodenal switch. And in fact, my first gastric bypass, Nicola Scopanero, who really developed that technique, was in New York at Mount Sinai with 7 of his colleagues to watch Michelle perform a laparoscopic DS. And I jest you not, my first gastric bypass, there were 8 Italian surgeons in the room watching Michelle walk me through my first procedure. And I know that because Italian surgeons, if you've ever been in an Italian operating room, the professor wears the mask, their nose is exposed. Everyone else, the mask is over their nose. They all had their mask. Our nurses weren't too happy about that, but their mask was below the nose. Anyway, the operation went well, but I was super stressed out. We started to look at our outcomes, and we were doing DS in our heaviest patients, the highest risk, most challenging patient population. And so roughly our logarithm is BMI greater than 50 DS, less than 50 gastric bypass. And then we looked at our outcomes and we realized that for our patients with BMI greater than 60, our outcomes were not so good. We had a very high unacceptable mortality rate. And rumor has it that Michelle was doing duodenal switch, the first part of which as a sleeve gastrectomy, and the patient had a tachyarrhythmia after he completed the sleeve, and they had to abort the operation. And there was a light bulb that went off. He's like, why not do a sleeve, downstage the patient, almost like giving a patient neoadjuvant chemotherapy, let them lose weight, then bring them back when the metabolic intra-abdominal syndrome has somewhat resolved, and do the more technically challenging component of the operation under better circumstances. And that's how sleeve gastrectomy was born as an operation. And this is the first report of a standalone sleeve, to the best of my knowledge. One of our fellows wrote this up, Joe Regan, where this became the technique. And you can see that now gastric bypass and sleeve gastrectomy are really the two main operations. And I think sleeve gastrectomy is the most commonly performed GI procedure by trainees around the country. And we've achieved really, really exceptional outcomes. So I think this is a very relevant quote. I was just smart enough to know I wasn't smart enough to do it on my own. So when you're a member of a team, you all have your roles, you all contribute, but knowing that you need to rely on your colleagues and work together is really, really important. So leadership and innovation are often essential in resource-strained environments. Now I know Dr. Wren will like this as her leadership activity in the global surgery realm. I had the great privilege of doing really my first mission trip 2.5 years ago at Tenwick Hospital in southwestern Kenya. It's just a remarkable place. Morning runs amongst the tea farms, up early. This is a sunrise on the way to the operating room theater. A very humble, grateful patient population, but a lot of pathology. Here's an example of a young boy you can see seated here. He was sitting in a field and a herd of cattle came running by, and he was eating a corn and he choked on the corn. He got so startled, and this kernel cob enlarged in his carina. So he was in stridor, but very calm. And we took him to the operating room and were able to successfully extract the foreign body. This is my first night on call. This is a cop whose partner accidentally dropped his AK-47 and shot him in the buttock and blew out his groin. Unfortunately, it missed all the great vessels, and we had to do an orchiectomy, but he survived. And this is my first night on call. And this is my last case of that 2-week experience. This is a fungating tumor. The patient came into the emergency bay in extremis, and rather than scan him, we took him straight to the operating room. That's when we first looked in his mouth and saw they had a fungating tumor, and we did a slash trach, and he took a deep breath and then went to sleep and survived, but then went on to be referred for radiation therapy for, you can see, this extensive nodal disease. This is through the Pan-African Academy of Christian Surgeons, a wonderful organization that I'm getting more and more involved with, and it's a great privilege to be a part of that organization. Here's what I really know how to do, which is thyroid surgery, but this was a complicated case at Tenwick. You can see this very thin airway over here, and I think this is probably one of the biggest substernal goiters I've ever seen. And you can see the patient here, it went anterior and posterior, and the patient really was not able to breathe. So this was a life-saving operation, but we were worried about how to intubate the patient. So here's innovation, simple innovation. This is Dr. Agneta Ora. She's the cardiothoracic fellow at Tenwick, working under Russ White. And we got a couple of endotracheal tubes, pediatric endotracheal tubes. We wedged them together, and we had a stylet that we could pass. This was plan B in the event plan A did not work. Fortunately, plan A worked, and we were able to intubate the patient and pass a very small pediatric endotracheal tube distal to that area of obstruction, and then do what turned out to be a very complex operation. But this is innovation, being prepared for all scenarios. Here you can see we did a sternotomy and excised this very large tumor. And here's the PGY4 resident, Frida Odega, that was part of our team, and the patient. She sent this to me several months after with the patient back for her postoperative evaluation. So even in resource-strained environments, it's possible to innovate. In fact, you have to innovate when you just make do with what you have available at your disposal. Now, the final chapter of my talk is around crisis. And crisis really affords an opportunity for technology, innovation, and leadership. So when you have a crisis, there's often induced innovation. You have a rapid rollout of new technology, the repurposing of ancient technology and personnel, entrepreneurship, and then it's really interesting to observe how different people respond to a crisis. Some crumble, some rise to the occasion, and then there's everything in between. I've really enjoyed hearing the wonderful presentations about COVID. I've learned a lot from yesterday's lunch session and other presentations. But clearly we're in sort of a very unique environment. I know we have a little bit of fatigue about this topic, but I just want to walk you through some things. So this is from the state of Kentucky, and this shows sort of what's happened in our state. We had a flat curve here. We had a peak from October to about April, and then now, of course, we're in the midst of this surge. And if you look at the hospital-induced resources or used resources, the ICU beds, and the number of total beds being used. We've created a tiered strategy, and we are now in tier 4. And because of that, we're not allowed to travel. So I canceled my flight on Thursday and made the drive from Lexington to Atlanta to, again, not trying to lead by example. I really wanted to be here. So here are the categories. So if you look at March, April, you had fear, anxiety, and the unknown. We didn't know if this was going to be like Ebola or really what was happening. There was preparation, planning, and process implementation. Then May of 2020 to June of 2021, we had acceptance, resilience, and quite frankly, complacency. And I'm sure you can relate to this. During that time, though, we worked on process improvement. The processes that have been developed and implemented were improved upon. And I really take a shout out to Emory for the work that y'all are doing with your process implementation. It's really remarkable work. And then July and August, now we have anger, frustration, and definite fatigue to be going through this again. And really, we are struggling with this. We're trying to cope. So I want to take you back, though, to March of 2020, and our modeling, we were using initially the Wuhan model that showed we were going to have up to 1,400 patients in our 900-bed hospital overrun with COVID. And in fact, we ended up being even less than the blue curve in the early days. We set up a whole field hospital. We didn't even fill a bed there. We're not doing a field hospital this go around because we think this will be a steep curve on the backside of this current outbreak, but a lot of anxiety in the early days. And it brings to mind these characters in Albert Camus' The Stranger, Meursault, who basically was detached. His mother died. He showed no emotion. He then killed a person of Arab descent on a beach, and he went on trial. In his trial, he was really on trial for his character, not for the crime he committed, but he was totally removed from reality. And then you have La Peste, or the plague, very relevant. And you have a plague that broke out in Oran, Algeria, a large city in Algeria. And the principal character who's telling the story, Bernard Roux, basically is, can't believe that the bureaucrats aren't getting their act together. And he takes matters into his own hands and implements sanitary measures, very relevant to today's times. And then you have Joseph Grand, who is a civil engineer, and he gets paralyzed by the pandemic. He can't function. He's trying to write a book, and he can't get past the first phrase of the book. He writes it over and over again and is stuck. We had a nurse in the operating room in March of 2020 who froze and had to be relieved of her duties because she was so terrified about the unknown. It's really, really interesting how people respond. And we supported her, of course, and she was allowed to go home. So these are the slides I showed. I was a new chair. I was thrown into the fire. And so these are the slides I showed. I started to have weekly meetings with the faculty in lieu of grand rounds. And I said, we are committed to being present and communicating frequently and honestly. We embrace the principle that core leadership during a crisis must exercise pragmatic optimism and empower those around us. And we have a responsibility to continue to fight the magnitude of this crisis and maintain resilience and patience. These are the kind of messages that I was delivering to the department who didn't really know me. They got to know me very quickly. And this is from me: careful thought, good decisions, and trust, not fear and panic, will get us through this crisis. People were terrified. We created this sort of tiered structure of what to expect. We looked at the Society of Critical Medicine staffing model, and because New York was ahead of us and I had a direct connection to my mentors in New York, I was able to learn what they were doing and bring that expertise and knowledge to Lexington. So we modified this technique and we created the platoon strategy, organizing our workforce to be able to care for what we thought was going to be 1,400 patients. Here you can see the planning meetings. We're mapping this out. We're putting the processes in place. We created a spreadsheet, what the companies and platoons were going to look like. And I bring to your attention, we put at the head of the platoon, the chief residents. This is the surgical company. The chief residents know how to get things done. The attendings don't know how to write an order in many cases, and I'm guilty of that as well. You can see this is the chairman of OMF, Marvin Yao, and this is me. We were lieutenants reporting to the chief residents, ready to go into battle. Fortunately, we never had to activate this plan, but it took a lot of planning nonetheless. We had to adjust who was going to be off, who was going to be on, preparing for the worst. We had to go back for practical training, and all of this was done. Here you can see this is our surgical company. We were going to be the first into battle. Volunteered us to lead by example, and I was going to be in the first platoon. We all had to go back and learn how to manage a ventilator. So we call this knobology. The respiratory therapist were instructing us on ventilatory management. We did dawning and doffing, proning position. In our simulation center, here's Dr. Andrew Bernard, our chief of trauma, again, doing different clinical scenarios, getting prepared for battle. And here's the dawning and doffing techniques. We had to partner with our external partners, how we were going to test our patient population. We really cater to 2/3 eastern part of the state of Kentucky, and we are the #1 transfer center in the United States. An incredible statistic that we're working hard. But we had to get the testing techniques with partners down. We had to do the rapid tests when we reopened for surgery. We paused for 4 weeks and then we reopened our elective surgical volume, and we had to put these processes in place. We quickly realized we were running out of supplies, so we partnered one of our innovation colleagues, Dr. Zhang from the Department of Biomedical Engineering. He and I have a very rich, robust collaboration between our respective departments. They created prototypes for developing masks and PPE. We ran out of nasal swabs. We were using vaginal swabs and whatever we could get our hands on to test our patients and our staff. This is a broom thistle that was being used to develop a swab. You can see that after a brief pause in our volume came back. And after talking about a telehealth pathway platform for 7 years, it got implemented in 10 days. Incredible. So really, really interesting work. We had to change how our waiting rooms function. You can go to the dentist's office and you get these nice messages, but to go into the physician's office, there's still a lot of wait. So how to make sure we didn't have patients accumulating in our waiting rooms. We had an EICU. This is Dr. Anthony Botigi, one of our trauma surgeons, and Dr. Hatton, anesthesia, and Dr. Fisher, and a remote access. We were just rolling out the EICU. And you can see I was rounding on a patient in the unit, a patient that operated with Cushing's. And you can see this is one of our trauma surgeons, Dr. Reynolds, leading a code. The patient was coding, the patient survived, but here's the EICU attending, interacting with the team, having an extra set of eyes in a stress-free environment, helping to direct the code. And we had set up this hub and spoke model where we were going to be actually transferring patients from these ICUs to our EICU on site, but we actually did the reverse during COVID, and we then went into their ICUs and were able to provide eyes on their patients and help them, our regional partners, manage some of their critically ill patients. I love this. This is the state of Kentucky, very poor eastern part of the state, very apt to flooding, just like in Middle Tennessee, and our thoughts and prayers go out to the 22 victims from the flooding that's occurred in Tennessee. You can see that this happens in eastern Kentucky. And here they had a hard time getting product, PPE, and supplies to people in remote locations. So the Rural Health Initiative at the University of Kentucky partnered with the drone port, which I didn't even know existed until I was researching this talk. There's a drone port in eastern Kentucky where the Department of Defense and others are testing drones. They basically were able to use drones to take supplies over the mountains to those that were cut off by flooding. And then finally, the vaccination story. This is my predecessor, Dr. Jay Swishenberger at the University of Kentucky. now professor and chair emeritus, he developed the Swish scale that many of you probably know of. And there's basically 3 or 4 components. The first is basically the autonomy of the trainee. Is it show and tell? Is it active help, passive help, or supervision only? He then merged that with the performance scale. So what is the performance of the trainee? Is it unprepared? Or they have an intermediate performance? Are they practice ready, or are they ready to roll? And then finally, you add the complexity of the case, easiest, average, and hardest. And many of you are familiar with this app, of course, Simple. Here's some of the data. Dr. Swishenberger gave me these slides for this presentation. You can see, though, by the time you're a chief, you're able to put these components together and really understand the autonomy, the performance, and the complexity of the care that's provided. And this has led to the Simple program with now over 140 residency programs participating, and a site in Kenya. Actually, Tenwick is participating in Simple as well. So really, really interesting. But from that, Swish has developed sort of the low fidelity simulation suturing lab, taking individuals and training them using artificial skin, practice boards, elastic bands, and so forth. And so here you can see this is high school students, college students, medical students. All of our residents are allowed to participate, and they teach each other. It's kind of the Montessori approach, different things. And I'm particularly like this because that's my daughter, Frances, who's a senior in high school, doing this with Swish this summer, participating in this future lab. I think she wants to be a lawyer, we're not sure, but she's interested in medicine as well. Here you can see some of the students that are doing their techniques, perfecting how to place a suture, increasing the complexity, suturing under tension, doing aortic surgery simulation and vessels under different conditions. Here is a model of a pulmonary vein injury and how to prepare in a box. So they're doing it with the box open, and then with the box closed, and then they time themselves, make it a competition. A lot of interesting data coming from this. But because this platform was in place, Dr. Swishenberger, and I give him great credit for this, we didn't have enough people to give vaccinations when this came on board in January, February. So the medical students have pretty much been put aside and we're not allowed to do much. So they were re-energized by developing the simulation of how to give a vaccination. So this is first and second year medical students and third year students learning how to give a vaccination, and then they were deployed. And our medical students at UK gave over 4,000 vaccinations. Just a remarkable, remarkable story. So this is my last slide. I'd just like to conclude. First of all, thank you for your attention. It's a great honor to be here today. And I think really it's the people that make innovation, technology, and leadership possible. And without people, without exchanging ideas like we're doing here today, these principles would not be possible. So with that, again, thank you so much for the honor of being here. And Dr. Richards, congratulations on your presidency. Thank you.